Hello, everyone. We have a 44-year-old man who had an extensive small bowel resection for Crohn's disease. He has been on total parenteral nutrition for last 2 years, and now he has come to hospital with epigastric and upper quadrant pain. Ultrasound shows lot of gallstones. 2 years back, there was ultrasound was normal. There were no gallstone. That means whatever happened in the last 2 years, and he is on total parenteral nutrition for last 2 years. Now, most likely cause of this patient gallstone is answer is gallstone stasis. Gallbladder stasis is the most likely cause of gallstone formation in this patient. Presence of protein and fatty acid in the duodenum act as a stimulus for release of cholecystokinin in the normal physiology, which in turn stimulate the contraction of gallbladder. Patient on total parenteral nutrition or prolonged fasting, the normal stimulus for CCK release and gallbladder contraction is absent. So there is no stimulus for gallbladder to stay contract. There will be stasis will be there. This leads to biliary stasis and promotes the formation of bile sludge and gallstones. Small bowel ileal resection contributed to formation of gallstone in this patient. Decreased enterohepatic circulation of bile duct result in altered hepatic bile composition. Well, small bowel has been resected, and you also know very well that the part of small intestine which is most commonly involved in Crohn's disease is distal ileum. And this enterohepatic circulation, it start from the distal ileum. So that part is gone. So there is hampered enterohepatic circulation. This becomes supersaturated with cholesterol. So now the bile becomes supersaturated with cholesterol and promotes gallstone formation. Let's look into other option. Option A, estrogen-induced increase in cholesterol secretion. This is the underlying mechanism for development of cholesterol gallstone during pregnancy and women taking oral contraceptive. This is not a mechanism in case of surgery after Crohn's disease. Well, cholesterol gallstone. During pregnancy, estrogen causes increase in cholesterol secretion, and cholesterol causes a reduction in bile acid secretion, causing increased cholesterol saturation of the bile. Progesterone also slows gastric emptying, gallbladder emptying, and thus facilitates formation of cholesterol gallstone during pregnancy. Now, let me tell you briefly about pathogenesis of cholesterol gallstone. Normally, normal level of cholesterol, bile, and biliary micelles and vesicle remain unsaturated with cholesterol. But when the cholesterol increases, bile decreases and decreased phosphatidylcholine, which happen in pregnancy, bile becomes saturated with cholesterol, and that lead to stone formation. Hypertriglyceridemia can predispose to gallstone in some patients, but it is unlikely. It's not a very important predisposing for cholesterol gallstones. Increased enterohepatic recycling of bile acid. Bile acid would not predispose to gallstone formation. It is reduce enterohepatic circulation, what we had in cases of Crohn's disease surgery. Decreased enterohepatic cycling of bile acid, as seen in patients with ileal Crohn's disease or ileal resection, can predispose to cholesterol gallstones. Okay, so this is due to increased concentration of bilirubin, conjugate, and total calcium in the gallbladder that lead to cholesterol gallstone formation. Increased RBC dissection, which is a hemolytic anemia, it increases to pigment gallstone by increasing amount of heme requiring degradation to bilirubin. Okay, so in hemolytic anemia, it is a pigment gallstone, not the cholesterol gallstones. This is cholesterol gallstones, pigment gallstone. You can see beautiful pictures. Golden line to remember: total parenteral nutrition cause gallbladder stasis and predisposed to gallstone formation and bile sludging. Thank you very much.